I've been given this topic and I learned myself really a lot because I thought, how can somebody talk about 10 minutes about this topic? So the question is, does the bone quality on the acetabular side influence the surgeon's choice? To make it clear, I think probably not. So I think hardly anybody of us looks at these and say, maybe I use these kind of cemented or non-cemented cups. So more probably we have got a range of cups we always use. But going through the presentation, I think maybe it should matter what we choose. So those are my conflicts of interest. So we know all that after nearly 20 years, the survival is nearly 90% of all the patients in the Australian Joint Registry. If you split them up, we see we've got two major reasons for revision, loosening and fractures. So if you look first at the topic of periacetabular fractures on the acetabular side, when we look at the literature, there's hardly anything which really tells us about the incidence of those fractures. Most publications, they really combine the stem and the shaft. And we know on the stem side, it's clearly uncemented stems. They've got an increasing risk of periprosthetic fractures, not just linearly, but that's going exponentially up. But there are a few studies who looked a little bit on occult fractures on the acetabular side. And this publication by Hasegawa, they found that nearly 8% of all the cases, they found some sort of cracks around the acetabulum. And if you look at the risk factors for those acetabular fractures, I think those are the most common bone diseases we know, but there's only one remaining, which really tells us, yes, there's a risk factor for a fracture, and that is osteoporosis. And that is this publication by Mick, and they looked at more than 52,000 total hips, and they found that especially females over the age of 70 with osteoporosis, they have got a direct relation to periprosthetic fractures, not just of the femur, but also of the acetabulum. But I think if you look at the fractures, probably it's more important than osteoporosis, probably the implant itself. There are two cup designs which are really prone for those kind of complications. One is the peripheral self-locking cup, has got a significant increase of number of fractures, and also the elliptical monoblock cups. They might be at risk if you go line to line with reaming. But I think probably one of the most important things, probably the surgeon's factor. How you see if somebody uses the Tor's hammer, like this surgeon, you maybe have got a high risk to really split up the acetabulum. So if you look at the second factor, that's the loosening. So bone quality and loosening. So loosening, we know this study here, nearly 14 years ago, they looked at the bone mineral density, and they measured in those patients also vitamin D, the parathormone, alkaline phosphatase, and calcium. And what they found clearly that patients with osteoporosis, they've got a higher risk of becoming a loose cup if it's uncemented over the period of time of 12 years. And that has been shown also by this study by the RSA. So you're going to implant small tantalum beads into that acetabulum, and you measure the migration of uncemented cups. And what they found is there is an increased migration of cups with decreased bone mineral density in the first 3 months up to 0.2 millimeters. But once the 3 months are over, they're stable. But this study showed that if the migration is more than 0.2 millimeters, then definitely the cup is at risk, because if the migration of the cup in the first 3 months is more than 1 millimeter, you've got a very high chance the cup becomes loose. So osteoporosis can affect the late stable osseointegration of the cup. Important, that's probably the only page or presentation I could cite a paper from the Lancet. So the Lancet is normally a medical journal, but here in orthopedics, that's my only Lancet reference. They published in the year 20 years ago that in particularly hypertrophic or atrophic osteoarthritis, they have got a high risk of a loosening of the acetabular cup. And they found here really that the survival rate decreased significantly after 8 to 10 years in patients with this kind of a primary osteoarthritis. And they hypothesized that probably because of the weakness of the tubercular structure, then they maybe break and the cup becomes loose. But I think probably more important is what's happening in long term with the acetabular bone quality. And I think that's a factor, that stress shielding, which is an important factor. If you look at those two X-rays, you can clearly see something has changed behind the cup. So 2016, there's less bone density behind that acetabular side. to understand a little bit how the load is transferred in a healthy hip, I think Karl-Heinz Wittmer showed it us, and they measured in the frozen human pelvises, they measured this joint distribution in the native hip joint, and they put Fuji films in between the head and the acetabulum. And interestingly, the load transfer from the head to the acetabulum is through the ilium, the ischium, and the pubis, but central in the area and all in the peripheral rim, there is no real load distribution. And that doesn't change even if you do partial weight bearing or full weight bearing, you just increase the numbers. And based on this, it was Manley who developed an FE model to simulate a little bit the same loading patterns in the native hip. And they found then, by simulating different cups with different strength, let's say cobalt chrome, the stiffest cup, to polyethylene, they found the weaker the cup is, the stiffness modulus, that you have got a higher peak stress, which is distributed over a larger area. And in the same study, they were also able to show that if you have got maybe more stimulus to the bone, that you even improve the bone formation behind the existing cup. That has been proven by post-mortem analysis. This study here, they had 5 pelvises on an average of 9 years after the patient they died. And they measured the bone loss behind the acetabulum in 3 areas. And they found that the bone loss was the highest behind the caps, just superiorly, when the cup was the stiffest, like a cobalt chrome cup. In DEXA measurements, similar results could have been found. In this study, they used 20 modular cups. They used either ceramic inlay, a stiffer inlay, or a polyethylene inlay. And what they found, if you use ceramic, so it's a stiffer inlay, then you increase the cortical density, but on the other side, you decrease the cancellous bone density. And that's a consequence of using a stiffer implant. And on X-rays, there are several publications out there who showed that if you have got a more flexible cup, that the incidence of acetabular osteolysis is significantly reduced compared to a stiff modular cup. So in summary, I can say that the acetabular bone quality has got an influence, in particular osteoporosis for periprosthetic fractures and loosening. All other systemic bone diseases don't really affect those 2 factors. Hypertrophic osteoarthritis is a risk factor for loosening, so in these cases you should consider maybe to use a well-cemented cup. And what we have to know that all our patients, mainly, they're getting older. So most commonly they have got an atrophic osteoarthritis, and very often they've got osteoporosis. So that should be an important factor we should take into consideration when we decide for the implant. Stress shielding causes changes of the bone behind the cup. And maybe these changes, they predispose that maybe the cup can migrate. It facilitates that the wear particles migrate behind that acetabulum and can cause some secondary mechanical failure. I personally also think that if stress shielding can cause some groin pain, because we know it from the femur, the different E modulus in the different stiff stem and the femur causes up to 20% thigh pain. And I think that could be the same reason why some patients with a stiff modular cup have got some residual groin pain. So look at here, that's from the New Zealand Joint Registry. They revised nearly 20% of all their cups just because of pain. And I think a lot of it had probably to do with stress shielding. And all we know that it can cause also some problems with revision surgery. So when it comes to bone quality, I think, or let's say fractures, I think probably the most important factor is a prevention of a fall. So you can prevent the fall maybe in this way, or what I do is I think all of my patients, which I see in my outpatient clinic, if I see they've got some osteopenia, if they're a little bit older, all the females above 70, I give them vitamin D, a new prescription, and I use personally either a flexible cup, which can stimulate the bone formation, or I go for the cemented cup. Thank you very much for your attention.